Hello, followers of Network Takeaway. Welcome back to the channel. Today, we are going to talk about imaging progression in MS. To start, I would like to remind you of some old new concepts. You have here the several curves of the disease that you all know very well, the different phases, the preclinical, the relapsing remitting, and the secondary progressive phases. Let's start with the exacerbations or the relapses. What is an exacerbation? Well, the definition implies a worsening, a clinical symptom that lasts more than 24 hours and that tends to improve in the following days or weeks, partially or completely, and it is preceded by 30 days of stability. You can see here that these relapses appears in the clinical phase. Obviously, they have a high frequency depending on each patient, and then they tend to sparse over time in the secondary progressive, in the so-called secondary progressive phase of the disease. Here you have the lesions on MRI. These lesions appear in the preclinical phase. That's why we can detect some old lesions at the presentation of the patient. Then they have a high frequency. Some people think that you have between 5 and 8 lesions on MRI for each exacerbation. And then they tend to disperse over time as the exacerbations in the chronic phase of the disease. Here you have the disease burden. Then we have the brain volume, which is very important. You can see here that the volume of the brain starts to lower in the preclinical phase, and it steadily goes down over the course of the disease. But I would like to point out this curve, the clinical disability, which means progression. Progression means an accumulation of disability over time that does not improve. It's sustained, and it is not related to exacerbations. But we usually localize this progression in the progressive phase. So some people tend now or think that we can go back, follow this curve all the way to the start of the process, and this is the early progression of the disease, and this takes us to the concept of PIRA, which we talked about in some videos ago. PIRA is progression independent of relapse activity, or the more disruptive term of PIRMA, which is progression independent of relapse activity and MRI activity. So there are different constructs of the disease. You can see here on the left the Fred Lablin scheme, where the disease starts with RIS, radiological isolated syndrome. You have just lesions on MRI without clinical symptoms. Then the disease can go to a CIS, clinical isolated syndrome, then eventually to a relapsing remitting MS pattern that can finally goes to a secondary progressive phase, or according to some authors, even though some people think this benign, let's call benign form of the disease does not exist, but some patients have certainly a low frequency of relapses. Then we have the other possibility of evolution with a primary progressive MS that, according to Fred Lablin, can have activity which can be clinical or on imaging, or can be purely progressive. But this scheme is dichotomic and binary. And we have other schemes. For example, Tanya Kuhlman in the last Actrims showed this interpretation of the process where you have the inflammation and the neurodegeneration that coexist from the very beginning, although the inflammation is much more important at the beginning and the neurodegeneration predominates at the final stages of the disease. And the reason of this shift has to do with the exhaustion of several compensation ways of the brain, like plasticity, like mitochondrial decompensation, like reduced myelination or reduced perfusion. And there is a shift in the kind of lesions as well. So let's talk about these points. Well, this is a typical case. You all know this. You can see here the presence of some lesions at the beginning of the process. Sorry, they are isolated. There is no atrophy. Then you have this progression to a more confluent pattern. And finally, you can see here a lot of lesions, less white matter and less gray matter. You can see the dilation of the subarachnoid spaces and the ventricles. Sometimes it's useful to compare the last images with the first images in order to detect this atrophy visually if we don't have a software to measure the volume of the brain. We all know that MS patients may have different phenotypes. And this is a paper by Bielekova that shows that we can have at least 4 patterns. Some patients have low inflammation with low neurodegeneration. Others have low inflammation with high neurodegeneration, a little bit of atrophy. Then you have those with high inflammation that can be associated with low atrophy, or unfortunately those that have both high inflammation and high atrophy. And this obviously has to do with the specific physiology of every patient, which is not the same. Okay, in the last years, there was a trend to find some biomarkers to predict the future of the process of the disease with images, with serological markers, etc. But I would like to stress the importance of the basic lesions, the hyperintensities on T2 and flare, and the enhancement on T1. You can see this paper by Tintoret of 2019 that where she showed that the quantification of these lesions, these traditional lesions, matters a lot, because you can predict the evolution of the patient. In this case, how fast they reach this point of 6 in the scale of EDSS. And this is very important because we all know these lesions, we can measure them. This is still important. Another important point is the topography of the lesions. It is well known that the spinal cord lesions, as well as the brainstem and cerebellar lesions, are more dangerous. They imply worse prognosis and progression of the patients, and this may have to do with the specific T cell profile of the patient. Now there is some evidence that spinal cord lesions are associated with Th17. Meanwhile, supratentorial lesions are associated with the Th1. So maybe this has to do with this this prognosis, different prognosis. Another relatively new concept provided by Dyer from Buffalo is the concept of atrophied T2 lesion volume. In the past, we thought that any chronic lesion remains stable over time, but now we know that they can shrinken. You can see here the T2 lesion that shrinking over time, and this is very important because it is an independent marker of progression. And moreover, some people at the first glance can think that you have less hyperintensity, and that's good, which is all on the contrary, it is bad. Let's go to brain atrophy. Well, the Magnim's group showed very well that brain atrophy can start very early in the disease. You can see here the CIS, the clinical isolated syndrome, can be associated with more atrophy that controls. For atrophy, we have to do the sequence, the T1-3D, and we all know that atrophy is associated, unfortunately, with clinical deterioration on the cognitive sphere. And it's very important to note that there are different bars to study this cognitive deterioration. And there are now several very specific tasks that we can do to study and detect these problems. Well, to study brain atrophy, we can turn to these specific softwares, and now we have several curves that allows us to put our patients related to the normal population, and this is very, very useful, and we can follow our patient volume, brain volume over time. Moreover, now we can perform spinal cord volume, which traditionally is performed at C1, C2 segments. It is much more difficult to normalize, and there are several new techniques. For example, Olga Ciccarelli from Magnim's showed in the last Actives this complicated technique that very nicely showed to be more sensitive than the traditional technique to measure spinal cord volume. Okay, let's go to the cortical-juxtacortical lesions. Well, now we are able to detect some of these lesions with the 3D FLAIR and the 3D DIR, double inversion recovery sequences. We have to be careful about not to confuse these lesions with vessels, but having said that, they are very, very sensitive, especially for detecting these cortical-juxtacortical lesions, the type 1 lesions. We still are unable to detect these intracortical or type 2 lesions, or these type 3 and subpial lesions, which are very, very frequent. The aspect of the lesions is of this type, they are small lesions or long lesions, like the worm sign, but now we have the opportunity to detect them very easily with these techniques. Look at the thalamus, because the thalamus is associated with progression. It is associated with the clinical disability, with cortical lesions, and it is the lesion of the thalamus are very poorly associated with white matter lesions. So we have to look at the presence of lesions at this level, and if we can perform volume measurements of the thalamus and follow them over time. Other important concept, speaking about lesions, is the concept of active-inactive plaques. As we said previously, some of these chronic plaques don't remain stable. We talked before about the possibility of shrinking, and now we will talk about the possibility of expansion. These active-inactive plaques are one of the possible evolution of an active plaque. You have here an active plaque which is full of macrophages disseminated over all the lesion, and they can evolve to an active-inactive lesion where the macrophages are placed at the periphery of the lesion, and they contain iron. That's why we can detect them on this phase sequence of the susceptibility weighted images. As these, you can see these iron rings that are very easily detected on 3T, and we can detect them on 1.5 T as well. The other possibility of evolution is to an inactive plaque where there is no inflammation at all. These scalding lesions, also called cells, slowly evolving lesions, are very important because they tend to expand, and that's very, very correlated with progression of the disease. Here we have another one of these lesions in the middle cerebellar peduncle. You can see here the periphery of the lesion, which is hypointense because of the presence of these iron rings. This is a study by Fisher where he showed the presence, the relatively increase of these lesions, which are represented here in orange over time, but they can be present at the beginning of the process. Another important paper, in this case by Lucchetti, showed that these active-inactive plaques are related with more disability of the patients, and so they have a very important clinical implication. Well, in this paper, Hebb showed that these lesions are associated with less capacity to remyelinate, to remyelination. And this is very important because this means that probably in an inflammatory environment, the process of remyelination is more difficult. Another point that we can detect on imaging and has to do with progression is the presence of lymphoid follicle-like structures. You know that these structures can be detected in the subarachnoid spaces. They are very small nodules. We can see them on FLAIR after contrast enhancement, and they are related to the presence of B cells, T cells, reticulin fibers, and dendritic cells, and they are thought to be the cause of the presence of oligoclonal bands in the CSF of the patients, and they are associated with cortical lesions. The cortex subjacent to these follicles is more affected than the rest of the cortex, and that may be due to the presence of the production of some cytokines that can cross the pia mater. There are different patterns of enhancement of the meninges. This is a paper by Sivadinov on 70, after using FLAIR after contrast. And you can see that leptomeningeal contrast enhancement is about 24, was found in about 1/4 of the patients, but there is a vascular contrast enhancement in another 1/4 of the patients. And what is more important, they found this dural pattern of enhancement that is very, very interesting because it hasn't been shown before. And this dural pattern of enhancement may have to do with the presence of these lymphatic vessels that we now know that they are located at the periphery of the venous sinuses. Well, let's go to the microglial activation. These cells, now we know they are very, very important in the chronic phase of the disease. They are associated with the innate immunity. These microglial cells comes from the yolk sac, but in the brain, when they activate, when they get activated, they are very similar to activated macrophages. And now we have the possibility of imaging this microglial, activating microglial with this PK11195 binding that binds to a protein, TSPO, which is present in the mitochondrial membrane, and it is a benzodiazepine receptor. So this is very, very important because you know that the macrophages and the microglia can have 2 stages, two forms. They can be pro-inflammatory, but they can also be anti-inflammatory. So they are a very, very versatile cell. And it's amazing that now we can detect these lesions. Another way to detect these lesions may be with this contrast material, USPIO, which binds to the peripheral monocytes that then goes to the central nervous system through a very leaky and more permeable blood-brain barrier, and they goes to these chronic active-inactive lesions, and then that contains microglia as well. So indirectly, we can mark microglia with this contrast, which is now approved by the FDA. Well, to finish, I would like to show you these different patterns of evolution of MS patients. Some of them has a very bad initial clinical presentation, and then they tend to stabilize, but most of them have a steady evolution at the beginning with the exacerbations, but then they reach a point where they worsen very, very fastly. And we all see these cases. So maybe they reach a burnout point. So let's talk about the compensation mechanisms of the brain. Fleischer showed very nicely in this paper the plasticity using functional MRI and tractography. And he showed that patients with MS tend to use more cortex to perform a certain task, and they have more connectivity that controls. Another process of compensation may be the perfusion. It is well known that these black holes are located in the watershed areas of the brain, and they are not very frequent in the spinal cord or in the brainstem. And this is these are 2 papers that showed the importance of hypoxia and hypoperfusion in the process of the evolution of the plaques in MS. Well, now we know that we have to detect therapeutic failure because it may indicate the switch of the treatment. This is a paper from Argentina, my country, where you can see the recommendations for detecting therapeutic failure. And you can see here that if you have 3 or more new lesions or enlarging lesions or gut enhancing lesions, you can diagnose with that, only with the, imaging, a therapeutic failure. So it's very, very important to control and follow up our patients. The annual control that we usually perform should be performed in the same MRI equipment, and it's very important the repositioning of the patient following the subcallosal line. And finally, I would like to show you this surface effect of this Krieger pool model, which is very, very interesting. In this model, Krieger compares MS with a pool. The floor is oblique. It has a slope because the topography matters, as we said before, and spinal cord and optic nerve are associated with more vulnerable areas, and very rapidly shows clinical findings. On the other side, you have the cerebral hemispheres, which tends to be more silent, and in the middle, you have the brainstem and cerebellum. Then you have the clinical exacerbations that goes up over the water line, and then you have the water line. The water level line represents the brain reserve, and over time, this surface line tends to go down because of aging, basically, and the exhaustion, burning out of the different compensation processes. And he says that these exacerbations, the old exacerbations that previously were silent, tends to go up and can emerge. So this is like a revival of the old process. So this is very, very interesting. And with this, I would like to finish up, and thank you for your attention, and don't forget to subscribe to the channel. Bye-bye.